This is the second video in this 3-video series on acute kidney injury. By the end of this video, you'll be able to select and interpret appropriate diagnostic tests in a patient with AKI and to be able to identify the most likely etiology of AKI in an individual patient. So how does a physician go about determining which of the etiologies of AKI is most likely in a particular patient? With few exceptions, there is a list of diagnostic evaluations which should be undertaken in any patient presenting with AKI. They include the history, with particular emphasis on recent volume and color of urine, intake of fluids, recent infectious symptoms such as fever and dysuria, medication history, and recent IV contrast administration. The physical exam, with particular emphasis on what's called the volume status, which is the concept of how much fluid is in the body relative to normal. Assessment of volume status includes assessment of vital signs, the JVP, the IVC's appearance on bedside ultrasound, and the presence of edema. Now are the labs. There is a complete metabolic panel, which includes the creatinine, BUN or urea, electrolytes, and albumin. There is the urinalysis with microscopy, also known as a UA. Something called the fractional excretion of sodium and or urea, usually referred to as the FENa and FEurea. Next is something called the post-void residual, or PVR. This is a measure of how much urine is left in the bladder after the patient has voided as much as he or she can on their own. And last is an assessment of urine output. I'll talk about each item on the list in more detail. One of the more frequent diagnostic challenges with AKI is distinguishing prerenal etiologies from intrarenal ones. This is important because prerenal etiologies respond to corrections of deranged hemodynamics, such as either fluids or diuretics, whereas intrarenal etiologies do not. Prerenal etiologies also usually can be corrected more quickly. The presence of any of the following is suggestive of a prerenal etiology: hypotension, a current heart failure exacerbation, the current use of diuretics, or a BUN to creatinine ratio, as measured in compatible units, of 20 or more. The first three of those probably make some intuitive sense, but what about the last one? Why would prerenal etiologies be associated with a high BUN to creatinine ratio? To understand that, we need to look at how the nephron handles urea, water, and sodium, which will help us to understand not just this one lab finding, but others that we'll get to in a few minutes. Here's a nephron with the afferent and efferent arterioles, the glomerulus, and the various parts of the tubule. So water, sodium, creatinine, and urea all get freely filtered from the blood through the glomerulus and into the proximal convoluted tubule. From there, what happens? Well, some sodium gets reabsorbed in the proximal convoluted tubule, some sodium gets reabsorbed in the loop of Henle and in the early distal tubule, though those locations are not directly related to the issue at hand. Some sodium is also indirectly exchanged with potassium in the late distal tubule and collecting duct, a location where water and urea are also reabsorbed. Unlike all of these electrolytes and compounds, creatinine is not reabsorbed at any point along the tubule. What happens in the presence of a prerenal etiology of AKI? Whether it's true dehydration, heart failure, or hepatorenal syndrome, it looks the same to the kidneys in that a collection of cells in the afferent arteriole, called the juxtaglomerular cells, see a low perfusion pressure, and in response they increase their secretion of an enzyme renin. Renin secretion is the first step in the renin-angiotensin-aldosterone pathway. One of the downstream effects of the RAA system in the nephron is that aldosterone increases the absorption of sodium in the late distal tubule, and although it's not discussed as much, angiotensin II increases the sodium reabsorption in the proximal tubule. And water reabsorption typically follows sodium reabsorption. In addition to that, both low blood pressure and angiotensin II increase the release of a hormone called ADH from the pituitary. ADH's effect in the kidney is also to increase water reabsorption, but also urea reabsorption as well. So in summary, in response to hypotension, there is an increase in the activity of the renin-angiotensin-aldosterone system and an increase in the circulating levels of ADH. Together, those lead to an increase in sodium, urea, and water reabsorption. The net consequence is decreased urine sodium and urine urea concentrations relative to urine creatinine, and an increase in the serum BUN to creatinine ratio since urea gets reabsorbed but creatinine does not. This explains the increased BUN to creatinine ratio, as well as a couple other things we'll get to. Before we move on from discussing BUN and creatinine, I need to mention some limitations when using them to assess renal function. First, both of them can be unusually low in patients with severe malnourishment, chronic illness, or prolonged immobilization. Second, the BUN can also be unusually high in patients with acute critical illness who are undergoing significant protein catabolism. And last, the equations that are used to estimate GFR from the creatinine assume stable renal function, and therefore are not really accurate in AKI. For example, consider a patient whose creatinine has doubled in 24 hours from 1 mg per deciliter to 2 mg per deciliter. Even though based on the patient's age and sex, those equations might predict a GFR of 40 to 50, in actuality, it's probably closer to 0 in order for the creatinine to rise so quickly. I'll move on from blood tests to now talk about urine tests, and the first is the UA. For a more thorough discussion of the interpretation of the UA, please see my videos dedicated to that specific test. The link will be in this video's description. But in summary, there are some common patterns on the UA that will suggest specific diagnoses, or at least specific categories, based on the urine's general appearance, specific gravity, the presence of proteins, leukocyte esterase, nitrites, RBCs, WBCs, and casts. First, in patients with PreRINO etiologies, the urine will typically look very dark yellow and have a relatively high specific gravity, due to all of the water reabsorption that's going on. Protein may or may not be present, which is dependent upon how concentrated the urine is. The rest of the UA will be unremarkable, with the exception of something called hyaline casts seen on microscopy. ATN may be either dark yellow or amber. The specific gravity here is relatively low. There may or may not be protein, leukocyte esterase, RBCs, or WBCs. The most distinctive feature of ATN on the UA is the presence of so-called muddy brown casts, but they are only seen in the most severe of cases. The hallmark of AIN on the UA is the presence of inflammation without evidence of infection. So leukocyte esterase, white cells on microscopy, and in severe cases, white blood cell casts. Urinary tract infections causing AKI lead to the same findings on UAs that all UTIs do: cloudy and turbid in appearance, leukocyte esterase, and white cells. Sometimes, but not always, there will be a very small amount of protein, nitrites, and/or red blood cells. With the glomerular diseases, first remember that these are not common causes of AKI. In those diseases leading to the nephrotic syndrome, the urine may be foamy due to proteins decreasing its surface tension. Protein by definition will be severely elevated. That means 3 or usually 4+ on a conventional dipstick. And there may be fatty casts on microscopy. In nephritic syndrome, the hallmark is glomerular bleeding, so the appearance of urine will be red or brown. There will be dysmorphic red cells plus or minus some whites, and there will be red cell casts. Next, what is the FENa and FEurea? These are calculations based on both blood and urine tests, which are commonly used to differentiate PreRINO etiologies of AKI from ATN. The FENa has been in use longer and is more accepted, so we'll start with that one. FENa stands for fractional excretion of sodium. It is equal to the amount of sodium excreted in the urine divided by the amount of sodium filtered through the kidney. In PreRINO conditions, the kidneys think, rightly or wrongly, that the patient is dehydrated. Therefore, via the mechanisms I reviewed a few minutes ago, they will try to hold on to as much sodium as possible, so the total amount of sodium excreted is low, and thus the FENa is relatively low as well. In contrast, in ATN, the kidneys don't necessarily think the body is dehydrated and their tubules are damaged. Therefore, they may be unable to resorb as much sodium as they normally do. This results in a relatively high FENa. The FENa cannot be directly measured, but is instead calculated as the product of the urine sodium and serum creatinine divided by the product of the serum sodium and urine creatinine. The equation may be hard to remember or cumbersome to use, but luckily there are a few online calculators that are easily Googleable. What are the values that you are looking for? A FENa less than 1% or less than 0.01 suggests PreRINO etiologies, while a FENa above 2% or 0.02 suggests ATN, and values between 1 and 2% are compatible with either. There are three very important and common situations in which the FENa is not accurate: cases of mild AKI, AKI superimposed on significant chronic kidney disease, and recent diuretic use. For these situations, particularly the recent diuretic use, doctors often check the FEurea, which is based on an analogous principle and has an analogous calculation. With the FEurea, values under 35% suggest PreRINO, and above 35% suggest ATN. As mentioned before, the FEurea is not as well studied or accepted as the FENa. Aside from the creatinine, checking the post-void residual is probably the highest yield diagnostic test because it's fast and alerts you to the presence of a very easily fixed etiology. To remind you, the PVR is the volume of urine that remains in the bladder immediately after a person has urinated as much as they can on their own. The normal PVR varies a little based on age, but is generally quoted as being less than 50 to 100 milliliters in adults. However, it takes quite a bit of excess urine in the bladder before the bladder pressure reaches a point that would impair renal function. While I don't know of any widely cited value, in my experience in adults, it takes a minimum of 500 milliliters and sometimes more than 1,000 milliliters before a person's renal function is perceptibly affected. You may be wondering, how does one check a PVR? Well, there's two major options, each with advantages and disadvantages. First is something called a straight catheter, or more commonly a straight cath. This is a flexible tube that is placed into the urethra and advanced to the bladder, circumventing obstructions within the urethra or problems with the urethral sphincters or problems with bladder contraction. Its placement is similar to Foley catheters, except there is no inflatable balloon at the tip to keep it in place, so it must be removed immediately after the bladder has been drained. Straight caths are precise and also allow for sample collection. Unfortunately, they can be uncomfortable, as you might expect. The other option for measuring the PVR is to use a device called a bladder scanner. A bladder scanner is an incredibly simple ultrasound device where the probe is placed above where the bladder is thought to be. A button is pushed, and the machine provides a volume with a rudimentary, highly pixelated picture. Based on the appearance of the quote bladder in the picture, the operator may need to move the probe and try again until the bladder appears centered. The advantages of the bladder scanner are that it is very quick and requires minimal training to use it. This is not like a conventional ultrasound machine. One can be trained to use it in under 5 minutes. However, despite the machines typically providing 3 significant figures on their measurements, they are very imprecise. It's probably best to round off to the nearest 100 milliliters, and even that might be implying more precision than the machine actually delivers. In addition, these devices are inaccurate in the presence of ascites, since pockets of ascites fluid may look like full bladders to the machine. In practice, we usually are not worried as to whether a patient's PVR is 100 versus 125. We are instead worried as to whether it's 100 versus 1000. So bladder scanners are the much more common method for measurement, as long as a urine sample is not also necessary. Urine output should be monitored in AKI. We can say a patient has oliguria when the output is below 0.5 milliliters per kg per hour for at least 6 hours, or if it is less than 500 milliliters over the course of an entire day. If the urine output drops to below 50 milliliters for a day, that's referred to as anuria. Urine output helps to assess the patient's response to treatment, as it's much quicker than waiting for the BUN and creatinine to decrease during serial rechecks. It's also helpful for predicting which patients will need dialysis. There are a few additional tests which might be undertaken based upon the situation and the results of the basic evaluation. These include either a formal renal ultrasound or informal bedside point-of-care one. This can detect ureteral obstruction, which would be missed by a bladder scan or Foley placement. Also, it can detect unusually small kidneys, which suggest pre-existing chronic kidney disease. Urine eosinophils can be checked. This test is considered positive if greater than 1% of all white blood cells in the urine are eosinophils, though some literature has recently recommended a higher cutoff of 5%. They can be seen in AIN, though their presence is neither sensitive nor specific, and some experts recommend against ordering this test altogether. The urine protein can be quantified via a 24-hour urine collection. This can help diagnose some forms of glomerular disease. And finally, a kidney biopsy can be performed. Since this is invasive and carries some risk to the patient, it is reserved for severe cases which remain undiagnosed despite all of the above. As with many diagnostic dilemmas in medicine, both trainees and practicing clinicians often like to review algorithms for how to approach the problem. The difficulty with doing this with AKI is that there are so many considerations, it's hard to combine all of them into a single flowchart that will work for every patient. Plus, algorithms for the evaluation of AKI that you might find in the literature may be cumbersome or incorporate near useless tests like urine osmolality and the urine sodium concentration. What I'll show you now is the approach that I think comes closest to what I see hospitalists and nephrologists doing in real life and what I would personally advocate. After identifying a patient as having AKI, the first step is to check a PVR to look for urinary obstruction. Regardless of history or exam, if the PVR is greater than 500 to 1000, place a Foley catheter to drain the bladder. At that point, watch urine output and recheck the BUN and creatinine in 8 to 12 hours. If renal function improves, you're likely dealing with a neurogenic bladder, BPH, or side effect of an anticholinergic or opiate medication that you've just temporarily addressed with the catheter. On the other hand, if the renal function does not improve with Foley placement, or if the PVR was not very elevated to begin with, evaluate the patient's volume status. If the patient is clearly hypervolemic, consider the possibility of heart failure and prerenal AKI related to that diagnosis, or that the patient actually doesn't have AKI at all, but rather chronic kidney disease, which will frequently be associated with hypervolemia. If the patient's volume status is either euvolemic or hypovolemic, the next step is an empiric IV fluid challenge, usually done with isotonic crystalloid such as normal saline or lactated ringers. If the renal function improves with this, wonderful. You know you are dealing with dehydration. But if the renal function does not improve with IV fluids, assess UA and FENa or FEurea if the patient has recently received diuretics. If the urine has white cells, plus or minus white cell casts, but without bacteria or UTI symptoms, consider AIN. If the UA has red cells, plus or minus red cell casts, consider nephritic syndrome. And if the FENa is above 2%, there are muddy brown casts, or particularly if the patient has concurrent sepsis or shock of another etiology, that's very likely to be indicative of ATN. Finally, if the UA is normal except for hyaline casts, and the FENa is less than 1%, consider whether the patient may be dehydrated after all, and that you just haven't given them enough fluid yet for the kidneys to respond. As I said, the algorithm is an approximate representation of what's done in real life, but there are many additional considerations that might lead one to do something or conclude something different. Here's just a few. If the patient has a history of cirrhosis, consider hepatorenal syndrome. If they've received IV contrast within the past 3 days, consider contrast-induced nephropathy. Recent administration of nephrotoxic medications, consider drug toxicity. Concurrent rash, fever, and/or peripheral eosinophilia, consider drug-induced AIN. Concurrent rhabdo, consider heme pigment-induced AKI caused by myoglobin. Concurrent hypercalcemia from any cause, consider if the hypercalcemia is the direct cause of AKI. Concurrent anemia and hypercalcemia, consider multiple myeloma. And last, if the patient is receiving chemotherapy, consider chemotoxicity and tumor lysis syndrome. That concludes this video on the evaluation of acute kidney injury. Part 3 will cover complications, presentation, and treatment.